That music was amazing. I am Larry Scott Walker. I'm the executive director and co-founder of Thrive Support Services. Thrive standing for Transforming HIV Resentments into Victories Everlasting. We're based in Atlanta, Georgia. We have the largest network of Black gay men living with HIV in the country. Uh, Presenting today with me are two amazing individuals that I look up to greatly. First, we'll hear from Dr. Austin Chan. Dr. Chan is an assistant professor at Morehouse School of Medicine and Infectious Diseases. He is also the principal investigator for the Georgia chapter of CTEC. He graduated from Emory University School of Medicine and completed his internal medicine residency at Emory as well. He is a Duke University trained fellow in infectious diseases where he specialized in clinical pharmacology and early phase clinical trials. His clinical research, as well as his passion, centers around HIV, Hep C co-infection, and access to care. I'm super excited to hear from Dr. Austin Chan. Up next will be Jim Sacco, licensed clinical social worker. He's a consultant and trainer based out of Asheville, North Carolina. Great vibes in Asheville. His training expertise includes a wide range of social work, mental health topics, including communication skills, addiction, sexual health, case management, and motivational interviewing. As a clinician, he has provided services in medical, substance abuse, and community-based counseling locations. His previous training clients include the World Health Organizations, the Center for Disease Control and Prevention, Emory University, Duke University, HIV community-based organizations, and state and local health departments throughout the southeastern United States. Since 1986, he has provided training for more than 50,000 healthcare providers. I'm so excited and honored to be sharing space with both Dr. Chan as well as Jim Sacco. Here we are. Before we begin, we would like to thank Thera Technologies for sponsoring us to provide this important space with you. First up, we will hear from the amazing Dr. Austin Chan. Dr. Chan, are you still on mute?
Yeah, sorry, just unmuted. Thanks so much, Larry. So I'll just be reviewing a quick medical review and then some Mythbusters. And then, of course, I'll hand it over to Larry and Jim after that to go ahead and talk about, stigma, sexual health, surviving in the time of quarantine, and all those kinds of issues. Next slide. So here, just an inspirational quote. I think this was Jim's quote from before. As a person living with HIV and other underlying ailments, it makes me look at others in my life who have been affected and have fallen ill, who are not living with HIV, and it made me take it seriously. It makes me want to continue my meds, keeping my system healthy, and try to maintain a positive attitude. Looking to the future keeps me in a positive headspace. I think people just right now, we all need a little bit of good news, and I think it's important to know that we can get through this together. So good inspirational quote there. So first thing I wanted to discuss was the idea of, COVID versus allergies versus the common cold. I think the big differentiator here, we kind of mentioned this on the last talk, is really COVID-19 versus other allergies. I think if you have common cold symptoms or flu symptoms, you should absolutely get tested. Obviously testing capacity varies place to place, but in general, if you're having fever, absolutely. Dry cough that you don't think is related to your allergies, definitely go ahead and get tested. We know that you can have some postnasal drip leading to a dry cough, especially if you have peak pollen season and you have, tree pollen allergies. But make sure you're up to date on your allergy meds and really be asking yourself if this feels different than what you're normally used to. Next slide. So, unfortunately, the testing scenario is highly variable, state to state, county to county. I think a good place to start is always with your local health department. In addition, your state health department website should have at least some kind of hotline to direct people. Speaking of the Georgia situation, a lot of our hospitals, of course, have testing up and running with limited capacity. But in terms of testing people outside the hospital setting, most of the time you have to do a call ahead where, you'll do drive-through testing and they'll kind of pre-screen you for your symptoms. So again, your health departments are probably going to be your best resource here. but unfortunately things are just highly variable, state to state, county to county. Next slide, please. So, when to seek care, when to stay home. I think, personally, I would say in a perfect world, everybody would get tested, even those folks who don't have symptoms. But if you're in an area, where you have access to medical care or you can get there, it's okay to say to yourself, let me call the hotline if I'm having some symptoms. Let me see if I qualify for screening. Always okay to call, always okay to check in with your healthcare provider. But when should you really go to the emergency room? Shortness of breath is really going to be the big thing. If you're feeling shortness of breath way out of proportion to usual, with activities that like cleaning the house or walking to the kitchen, that, it's completely abnormal for you, I would definitely go seek medical care, go to the ER. And of course, pain in your chest as well. Chest pain is always very scary. If you encounter a loved one who's confused or has a bluish tinge, definitely go to the ER immediately. I think what we've seen in New York is that there's been a lot of, people unfortunately passing away at home. And so I think it's okay to be a little bit cautious here. It's unfortunately with the situation it turns us all into hypochondriacs, myself included. But what I would say is, it's okay if you're scared, it's okay to go to the ER, get tested, get reassured. If your symptoms aren't too concerning but mildly concerning, at least reach out to somebody, maybe talk to your primary care doc or a testing hotline. Next slide. So this slide kind of discusses, CD4 counts and the little bit of data we have on patients with COVID-19 and living with HIV. The only published data that I could really find was a 5-patient case series out of Barcelona looking at, 5 people with widely variable CD4 counts, and also some people not virologically controlled. Again, as of the writing of the study, all patients were alive. 4 had recovered. 1 was still in the ICU. But what we see, WHO has also released some statements saying that there does not appear to be any increased risk for patients living with HIV. They have some unpublished data from the Wuhan cohort. The expert guidance from CDC and WHO is that if you haven't achieved virological suppression or your CD4 below 200, that certainly may be in a risk. We're not sure, but it's always good to exercise caution. And then of course to keep that in mind with additional traditional risk factors as well: diabetes, high blood pressure, obesity. Those things can kind of be additive. In general, I would probably use the CD4 count of 200 or virologic suppression as the big cutoffs there, but we still need to get more data. This is rapidly changing. Again, probably by next week there might be a new study out, making this statement obsolete today. Next slide, please. So I think that's really important for people living with HIV and also just the general population to observe the standard hygiene and precautions that have been set forth. Hand washing is critical, especially when you're coming back home. If you had to go to the grocery store or something like that, make sure first thing you do when you get home is wash your hands. Next thing, physical distancing. If you do have to go somewhere, try to be at least 6 feet apart. That's kind of the accepted, droplet distance that people who speak generate droplets. Usually 6 feet is considered to be pretty safe. Try to avoid contact with other folks, or at least maintain a nuclear group of people who are isolating with you. And for those states who are maintaining a shelter in place, again, really important to listen to that. They're probably looking at their number of cases per day, where they are on the curve. That's the big discussion. That's kind of where I would put it. And then, of course, there's that relatively new guidance from CDC to wear a cloth mask in public. We'll talk a little bit later about the reasoning for that, but I definitely think it's a good idea. Everyone should be wearing masks at this point. And even if you're in a state, like I think Georgia just opened up restaurants and bowling alleys today, I think you should still observe these precautions. I think it's important to, limit exposure, limit risk wherever you can. And, these are just good basic guidelines. Next slide. So, talking about wearing the cloth mask, it doesn't necessarily prevent you from getting COVID-19, what you really, for example, if I walked into a patient's room and I had to see somebody with COVID, I would be observing the CDC guidelines of wearing the N95 and the goggles. But that's because I'm going into a close encounter with somebody who I know has COVID. In general, if you're wearing a cloth mask in public, the goal is to prevent you from spreading droplets everywhere else. So, I don't necessarily want people to have a false sense of security per se, but if everybody's wearing a cloth mask, overall it's limiting the amount of infectious particles in the environment, hopefully limiting spread. Certainly a good idea. And, I think a lot of people are making masks with inserts. I think that's totally fine. I don't, doesn't have any, government approval per se in terms of like meeting a specific infection control standard, but it certainly seems like a reasonable preventative measure. Next slide. And so there's been a lot of discussion about, should I switch antivirals with this? Are my antivirals protective against COVID-19? In general, what I would say for, people with HIV, take all the precautions in terms of getting your meds. I would not switch your medication. There's not any good evidence for that so far, and we'll certainly go through a couple of the studies that have come out. But in general, stick with your meds, take them. The best thing you can do for yourself is to, maintain a suppressed viral load, maintain a high CD4. That's the big thing. Certainly no need to switch to the lopinavir-ritonavir stuff, and we'll kind of go through the data that has come out so far. But as far as we know, there are no ARVs that have specific efficacy in preventing COVID-19 disease or preventing, acute respiratory distress syndrome from COVID. Next slide. So here's the COVID-19 and patients living with HIV lopinavir-ritonavir study. In this study, it wasn't necessarily people who had HIV, but were given lopinavir-ritonavir, and there was a control group. So first looking at the chart on the left of the screen, there you can see people recovering. That's the rate of recovery, and then time on the x-axis. Those curves were not statistically significant. You could argue that there's maybe a trend for the lopinavir-ritonavir curve, but again, when they did the statistical analysis, it was found to be not significant. And then again, over on the right, you can see viral load of SARS-CoV, not of HIV. So this is the SARS-CoV-2 viral load in the lopinavir-ritonavir arm versus control. Again, pretty much the same, and no statistical difference there. So in general, there was no benefit found from this particular antiretroviral. I certainly can't predict the future. There might be something out there, but this had been one that had showed in the laboratory that had kind of inhibited viral suppression, and that's why I was selected for the test. So just to summarize, stay on your same ARVs, no evidence to switch. Best thing you can do for yourself is maintain a suppressed viral load and maintain your CD4 count. So in terms of the risk factors for disease, they just published some data on JAMA looking at the characteristics of people in New York ICUs. And what we found is that, hypertension was big, obesity was very common as well, in addition to diabetes. Lung disease was actually not as prevalent as we had expected. Don't have a good explanation for that. That was something that came up on the other call too. But in general, what I would say, these comorbidities can be additive. So, if you're obese with heart disease and high blood pressure, that would put you at additional risk. I think everyone needs to be gauging their individual risk and kind of, maintaining their exposure a little bit differently based on that. And so, again, stick with all the basic precautions. If you have any of these additional risk factors, maybe go above and beyond, Clorox, the groceries that come in, that kind of thing. But then, of course, linkage, retention, and re-engagement for care for patients living with HIV is critical. We certainly don't want to find out after the fact that people with uncontrolled HIV were at high risk for COVID. We just want to try to get as many people drug as possible. I know for our ADAP, they have given us a little bit of amnesty. So, if people hadn't been able to renew in the last month or so, they had some extensions. I don't know if that applies more broadly. But again, shout out to all the linkage care folks, the ADAP coordinators out there. You guys are critical in this piece. And I think Jim and Larry will discuss that a little bit more too. So as states begin to reopen, including Georgia, again, still stick with those same precautions. We could get a second surge. There's some, health experts and, people at the CDC saying that there may be another winter surge. So we just have to be really, really cautious. Again, there's no data to suggest that people living with HIV are at more risk, but the existing risk is still really bad. And in addition to that, people living with HIV do have higher rates of heart disease, diabetes, high blood pressure. So those things are all additive. We're certainly taking care of a very at-risk population here, and we should advise them appropriately. And so if you can get hand sanitizer, I think it's great. Hand washing works just as well. And of course, I'll defer to Jim and Larry about talking about linkage to care and the appropriate resources. Next slide. So just a couple, things to dispel here. Just wanted to mention that, hydroxychloroquine, I think the jury's still out. The initial flurry was kind of based on bad data to begin with. There have been a couple unpublished studies, one from the VA, looking at a VA cohort, another study coming out of China showing no particular benefit. There was some chatter about heat, blowing a hot air dryer in your nose. Certainly my father-in-law tried that. I don't think that there's any efficacy there. It might damage your nasal mucosa more. Please don't do that. COVID-19, there have been some scattered reports that, came from a lab. Again, I don't have any additional information here. I think we just have to see how this thing plays out. The expert opinion, though, that this is not, a weapon of bioterror. That being said, N95s and P95s is the only thing effective. That's actually, not true at all. If you're a patient with COVID, it's very, very helpful if you're wearing a mask. And if you're in public, a droplet barrier mask is appropriate. Obviously, I think in places where there's shortages of PPE, do your best to try to preserve that for healthcare workers or donate stuff if you can. But if you're personally at risk, I think it's okay, to wear a droplet barrier mask in public. N95s are really just for close encounters with patients who have confirmed COVID in a hospital setting. Last but not least, does drinking warm liquids slow down some of the problems? Nothing, this is unstudied data. This hasn't been proven for other viruses, so I wouldn't necessarily say that's true for this one. I think Trump had a press conference talking about UV light and other things like that. Please don't inject any bleach or anything like that. So, let's just stay safe, talk to your healthcare providers. Again, it's hard to tell the difference between these kind of what's myth, what's reality, but we'll continue to have these webinars and do our best to parse that out for you. And that should conclude my portion. I'll turn it over to Jim and Larry, and of course, I'll be around for questions.
Thank you so much, Dr. Chan. I'm going to call up the next expert, Jim Sacco. Thank you much.
Okay. Good afternoon, everybody. Thanks for making time. As we've said, this is a follow-up. I'm not sure if everybody was on the first webinar, but part of what emerged in the comments, there were loads and loads of comments and a lot of unanswered questions, which is part of what prompted this, and a whole lot of emotional reaction to COVID. And so I start my talk with this reminder that our shared vulnerability, that is our humanness, can be, if we look at it from the other side, it can be what allows us to link arms in the fight against COVID. And the reminder, the virus is the enemy, not people with COVID or affected by COVID-19. A quote that we saw, and again, something we all wanted to remember. As I said, when we looked at the comments, people talked about, I'm feeling so bad, and why am I feeling so bad? And so what we want to do is really frame it as, in part, an emotional reaction to stigma. And some of you use the term. I'll show some comments in a minute, but we thought really for this webinar, we'd say who's experienced stigma and how has it affected us, and how does COVID-19 interact? I start with a story. A buddy of mine early on, this thing was just starting to look serious in the U.S. probably late March, called me out of the blue and said, "Well, I'm having some flashbacks. This is someone I've been around a while. This person had been around a while in the early days of HIV." And this dude said, "Man, I'm having some flashbacks to the old days. People afraid of one another, and this virus we don't know, and there's no treatment." And I hadn't really thought about it, but I knew I was feeling anxious. I knew I was feeling sad, and there was something in my belly that I hadn't named. And so when Dave said, "I'm having flashbacks to those battled early HIV days," I thought, wow, that is part of how we're experiencing it. As you guys talked about it, a number of you have had the same flashback. So there's a definition. It's a group of researchers at the University of Alabama, Birmingham. People at the 1917 clinic, those of you who live in Alabama know that clinic well, who've been researching HIV and the psychosocial variables for a long time. This is their definition of stigma. And I think as we try to unpack why we're feeling what we're feeling, in addition to the anxiety and stress everyone's feeling, those of us affected by HIV, living with HIV, who care about people with HIV, may in fact be experiencing something related to stigma. Here's a definition: socially undesirable attitude attributes which make you appear lower in status than other people, and consequently experiencing prejudice and discrimination. So the hallmark is because I'm different, I experience stigma, and that feels like prejudice and discrimination. We'll unpack more of the motion in a minute. Next slide. That's really what you guys said. These are direct quotes from people who gave us feedback on the previous webinar. And again, it sort of reinforced the need for us on this webinar to call it stigma, to kind of unpack where it comes from, and to talk about self-care. Again, I think for everybody, it's important to do hand washing and masks, and Larry's going to talk about safer sex, but my role really is to talk about safer self-care, and especially for those of us affected, deeply concerned, it's double stigma. Please address stigma. Somebody talked about PTSD from the early days. If you weren't around in the early days, I think whatever your days were when HIV first became real, when you first were diagnosed, when people you cared about were first affected, those are your early days. And whatever the dates were, those early days often have some pain. Next slide. Why do people experience stigma? As I said, people are viewed as different. These are some of the attributes that our culture, that multiple cultures say, oh, you're different and therefore not as good as. And again, I think many of these transcend our culture here in the U.S. Certainly, I think there's bias here. My partner travels overseas, and he's talked about in places he's been various tribal and ethnic tension, various ways in which socioeconomics sets people above or below, and certainly because he's traveled in parts of Africa and parts of Asia, places where sexual orientation is pretty rigidly defined. Okay, parameters are fairly rigidly defined. So because of this, people already have experienced some injury even before HIV came along, even before COVID came along. And so for all of us, I think most of us can see, I recalled as I was getting this ready, a young man in a middle school decided it would be a great idea to wait after school many, many times and sort of be mean to me and tease me and follow me home. And lucky that it didn't get worse, because I know people have been teased and followed and things got worse. It was name calling, but I remember that experience, and I look back and think, that young man certainly had to have experienced some abuse in his own life to have been that mean as an 8th grader, but also just what the lasting impact of that early injury can be for us. And again, these people at UAB and subsequent researchers looking at the interface between HIV and stigma tell us the impact can be that much worse. Next slide. And overlay sort of what the targets of stigma are about COVID-19 and in the world that we're living in. I have a buddy in Nashville, Korean American. He is born and raised in Middle Tennessee. He sounds like he ought to be. If you closed your eyes and heard him talk, you'd think he was taking tickets at the Grand Ole Opry. Old Bob. Bob is just a good old Tennessee boy who happens to be of Korean heritage, and he's talked on the Facebook in multiple posts about people striking out at him, at his 11-year-old son, because they are Asian American. And you think that in the country we live in, he did a thing. He took a picture of the woman. I say, good for her, good for him. Took a picture of a woman at Publix in the deli line who said he ought to go back to where he's from. Standing in the deli line at Publix, this hater had to say, "Oh, you brought, COVID-19." So a way in which COVID, I guess, like other illnesses, divides us. There's a blue-red thing. My New York City people, you're gonna raise some eyebrows when you show up at your family reunion in South Carolina and Mississippi this summer. I promise you. The whole idea that the myth that COVID is an urban problem, and I think some people that want to pit urban or rural Americans, it's not our problem. Mayor or the governor of Alabama who said she didn't want to go on lockdown because we're not California, we're not New York City, because of course the virus, COVID-19 cares if you have a subway system or not, apparently. The other concerning thing, and this is where stigma and stigma research overlap, and it's really important for all of us, that health outcomes, the impact of stigma, the impact of cultural bias seems to affect people of color differently than people who are European American. And so what we are starting to know, and we don't fully understand, is that early data, Chicago, DC, New York City, data says people of color are not surviving COVID at the rate we would hope. Some of that is about, as Dr. Chan said, is about premorbid medical conditions. But I think for all of us to kind of start to wonder about why people of color, back to the basics of social determinants of health, why people of color are not doing as well. I suspect access to care, economics, all kinds of other variables that affect outcomes from other diseases probably are at play here. A couple other things just to think about. Stigma for people that are still going to work. You're still having to go to work, depending on what your job is. There's a kind of where are you going and why are you going and whatever else. The last one that was raised in the planning call, part of this, is people having some stigma about who gets a check and who don't get a check and what they do with their check. And I thought about that as we were processing in our planning meeting. It reminds me of these conversations, muttered conversations behind the front desk of agencies, where people are muttering about who's got enough money to pay get their hair done or get their nails done or what kind of bag they're carrying. And I've called people out many times and said, if you think that healthcare is about you get to decide who gets their hair done and when they get their hair done and who gets their nails done, then you are in the wrong line of work. That's not our business. But I think this, again, the way in which stigma happens, this last reminder down there, these early HIV flashbacks, again, number of people talked about it. You saw some quotes. There were way more quotes than we even put on the screen, just because this is affecting people differently who are living with HIV. Next slide. I don't want to get too academic, but one of the interesting things about this look into stigma that I did was to talk about how the institutions in the culture start to embrace stigma. And they talk about how institutions and laws and policies start to reinforce issues of who's better or not better. And this dude in Columbia University, shout out New York City, very, very smart sociologist, talks about how laws and practices and structures in a culture start to reinforce you're bad, you're not as good as. And the schematic, there's sort of structural stigma resulting in a public shaming of people, stigma because you hang out with certain kind of people. I think the most damaging one over on the right there is how, as victims of stigma, if we're not really mindful, or as grown-ups, we don't come back and do the work, we can start to take on that junk and feel bad about ourselves in language that Hatzenbuehler calls self-stigma. We start to feel like we're not, that we are the things that people told us. Next slide. So what are those impacts? If we're not careful, if after the fact we don't come back and do our work, I'm not good enough, I'm not loved, I won't even read these. Most of us have had some struggle to overcome this. Again, I think the work of adulthood is to say I'm not willing to believe that anymore. I'm going to move away from not having anything to do with people that want me to believe this about myself. I'm going to make a life where the social structures around me don't reinforce the early stigma and shame I experienced, and I'm going to make my own way and write a new script. That's the opportunity to heal this junk. But again, I think as we look at that list, most of us can relate. Most of us love people that carry this junk around or have had to unpack this baggage in their adult life. Diana says, I shouldn't have been born. I see your comment, Diana. Thank you. Another comment. Next slide. So all of this, and what are the likely manifestations of COVID-19 stigma? Again, we've got all that background stuff, the anxiety of living with an infectious disease. The other thing that I've been saying on any webinar where people will give me a live mic is that we're in a kind of free-floating natural disaster. That one of the things that a colleague of mine, Hillary Bolton, here in town, did a video blog, and in her blog, and this happened at a time I was really thinking that I was crazy. The idea that she said on her Facebook video blog, she said we're all in a kind of collective grief, and it's affecting our cognitive ability. I mean, the title of her blog was kind of, this is why you're not making sense. And just the day before, I'd driven a route that I usually drive, and I went the wrong way on the highway, and I tried to get on somewhere else. Like in one day, I'd gone a couple different ways the wrong way. And I thought, you know, what if I got some kind of early Alzheimer's? And what she said, first thing, it started with our cognitive stuff is messed up because we're grieving. There's an anticipatory grieving. And I thought, girl, you win, because I thought, you know, I was ready to go to the Alzheimer's unit and lock myself up. So it's grief. All these feelings, as I look at these, are both about the uncertainty of COVID, but a lot of what's underneath this are feelings that I'd call grief, that we are in a kind of what the language that Hillary used, a kind of anticipatory grieving for what's ahead, grieving for people around us. We water signs, when I call out my water signs, we water signs are feeling way too much for everybody else. Pisces people, Cancer people, you know what I'm talking about. Next slide. The last sort of academic thing, that this is a woman at the University of Toronto, but more research on why, as people living with HIV, this is especially difficult. What she talked about is how, when you're living with HIV and you've experienced other prejudice, other discrimination, she uses the term intersectional stigma. That is stigma of living with HIV and sexual orientation, or prejudice because people are substance users or whatever, other fact, racism, homophobia, all of that mess coming together. She talks about how the road and the struggle for people because of the intersecting multiple stigmas can be that much more difficult for some people living with HIV. Next slide. I want to move to solutions. So what do we do? There's a couple of clinicians at Duke. I think they're psychologists at Duke. These next 10, on both of these slides, these next 10 factors are factors that prove resilience from trauma, resilience from living through stigma. And so it's a 10-question screening tool that she uses to determine, are people going to be able to survive the injury of stigma? How will they survive? I put it up today because I think for all of us, these are factors we ought to try to cultivate in ourselves, ought to try to cultivate in the people we care about so that we can all survive. And maybe that COVID-19 even becomes an invitation to heal some other stuff that's unhealed. So people who are adaptable, people who say, I can deal with things, people who are trying to have fun. I'm someone, a few of you on the call know what a goofball I am in real life. I try to have fun at work. I think it's a part of the human condition, and where you can bring humor, it tends to be a factor that creates resilience. Stress management, people who tend to bounce back, again, who experience a hardship and say, I'm someone who bounces back. Next slide. Adaptable, believing in oneself, sort of the ability to achieve goals, staying focused even under pressure, not easily discouraged when things don't go your way, strong person when dealing with challenges, and unpleasant or painful things, I can handle those. So these 10 factors, again, it's Connor Davidson resilience scale, but I put it out here because if these are factors that are related to how people survive stigma, then I think there's something, as I said, for all of us to sort of cultivate those internal beliefs for ourselves and to try to foster resilience in people we love, people living with HIV, and probably people living with coping with this sort of free-floating natural disaster, COVID-19. Next slide. Next two slides are about coping with anxiety. A comment from the first webinar, we need help us through being alone. And so I start with saying one of the things that's happened, it was starting in our previous webinar, but it's taken place. The World Health Organization has stopped using the term social distancing and has replaced it with the word physical distancing. So the idea that we're not distancing from people, we're just creating a physical barrier. I've found that I really need to see faces, hear voices. A text or an email is not enough for me. I'm really missing connection with some of my people, and so trying to figure out how to maintain and realize that those feeling connected to other people is a way I'm going to help cope with my anxiety. Trying to get out of yourself and help others. My challenge to all of us is, where is there an opportunity, even given the constraints of COVID-19, to feel like we are being helpful to others? We're making a difference in the lives of people we care about. Eat right, exercise, get outside. I've done a number of webinars where I ask people what they're doing to cope. Lots and lots of people are saying, I'm staying with my exercise thing. I'm doing yoga, meditation. A lot of people are saying, I get outside, try to get some fresh air. People talk about creativity. Whatever your way is, those are some proven techniques: good food, exercise, deep breathing. Watching overindulging is behind the quote. That means overeating. Man, it is tough. And I see all these people who are posting their coffee cakes and their recipes on their Pinterest and their IG. I think, girl, if you eating all those casseroles you're putting on your IG, you are going to come out with 19 extra from COVID-19. So anyway, overindulging food, alcohol, sex, gambling, you know who you are. Managing your anxiety by checking, no, that's fine, go on, we got it. Managing your anxiety by watching your thoughts. Listen to your self-talk. So what are you telling yourself? Are you scaring yourself? Or can you find ways to reassure yourself? Go to that place where you find your sort of own internal teddy bear, that own internal comfort blanket, and sort of say, tell yourself, I'm going to get through this. When you get into a scary fantasy, tell yourself, something new. And then this last reminder, change the channel. That is literally on the TV, cut off that news if you need to, change the relationships if people are draining you, wearing you down. And if you've got some loop in your head that's bringing you down, go ahead and change that channel. Next slide. Ways to manage grief. These are, again, if we're in a kind of grieving process, to allow our emotion to understand that there's no one way to get through it. It's going to be different for all of us, that it's not predictable. You're going to have a good day and a bad day, and then doggone it, another good day. People who live through grief get support. They lean on people that they know care about them. They develop a care plan. And this last bullet is important, to recognize what's grieving. That is sadness associated with loss, which is fluid and comes and goes, versus depression, which is longer lasting, which doesn't come and go, and which for the most part is going to need some professional intervention. And I'll just indicate if your sadness comes from a place of weathering this storm, or if there's a deeper, less fluid sadness to address. Next slide. I think it's the last slide. A call to action. Reach out. All caps, reach out. The last thing, the title of this webinar is Stronger Together. And the last thing I want to challenge people to do is to think about who's in your list of contacts on your phone that you haven't talked to for a while. Who's someone that you've fallen out of touch with? Who do you love that you haven't checked in with the last few weeks? I find myself really benefiting by saying, you know, when someone crosses my mind, how is X person, I go ahead and pick up the phone, pick up the text, do something. And so as you're thinking about reaching out, I want to challenge you to reach out with some reassuring thoughts. Some thoughts like, this is scary, just reinforcing for people this is a scary time and that fear is normal. Inviting people living with HIV or who've experienced the epidemic and the early injury, that there's some flashbacks going on, and that those flashbacks are real. The good news in terms of reassuring these people, reach out and tell somebody, most of us not going to get it. Most of us are not going to contract COVID, and even if we get it, less than 3% fatality at this point. Again, can you reach out and reassure somebody? We can protect ourselves, and again, in response to any early injury, you deserve to be protected. You deserve to protect yourself. Validating that people are feeling sadness and confusion. And maybe for people reaching out and saying, baby, we're grieving. Baby, we're grieving. You're going to be okay. We are grieving. That's the name of it, and we'll get through it. The last reminder, reach out and tell somebody to talk. Reach out and tell somebody to allow all their feelings. And I think to turn up the Gloria Gaynor in the background, or RuPaul, Diana Ross duet. There's a newer version. I love the RuPaul version. You know I do, Larry. And tell your friend, tell someone you love, baby, we will survive. With that, I'm going to turn it back to the boss. Larry's going to take us home.
That was more than amazing and informative. I'm trying to turn on all of my pieces here. I just want one note for everybody who's listening right now. If you have some questions that are burning you up right now, put them in the Q&A. And if you have any comments for us, leave them in the comments. And also for Jim, if, talking about people gaining 19 pounds during this COVID, if you got something to say to me, just at me on Facebook or Instagram. No, I'm just joking. Again, I'm Larry Scott Walker, and I am bringing up with the sexual health and COVID-19 section. This was a very popular question and request from the last training, and it is my pleasure to bring it to you. To begin, and I apologize about these animations, we're not able to move them out of the way, but to begin, I would like to start with H. Hunter Hansfield's advice from the American Sexual Health Association. We strongly recommend sexual active persons to be very selective in their sexual partnerships. Pay attention to your partner's health and limit new partnerships to fewest as possible. The lowest sexual risk, of course, will exist with a mutually monogamous couple. Okay, so let's just begin with some COVID facts. Again, COVID is spread from a person who has it, who can be asymptomatic or pre-symptomatic. It's spread through respiratory droplets, mucus, and contact with feces. Note, COVID is not a sexually transmitted disease. However, activities like kissing and rimming puts us at extreme risk for contracting COVID. Again, I'm sorry. Again, it is not recommended to that we have sex with anyone outside of our homes at this point because it goes against the physical distancing directives coming out of the CDC. And if you are someone who typically meets your sex partners online or clients online for sex, it's recommended that maybe during this time we take a break from in-person dates. The quick and the simple fact is that you are yourself safest sex partner during this time of COVID. So masturbation, maybe engaging some OnlyFans entrepreneurs during this time, or other sex sites. My Vidster is a popular one, Pornhub, and engaging in some safe sex, pleasure, understanding that there's actually proven health benefits to masturbation. This quote actually comes from healthline.com. There's no risk to masturbation in this time of COVID. In fact, orgasming is an incredibly healthy thing to do while in self quarantine or isolation, whether or not you're in a relationship. Experts agree that masturbation reduces stress, it helps us to sleep better. It strengthens our immune system and it boosts our confidence. And who couldn't use a little boost of the confidence right now? The second safest partner is someone that you live with who you can verify is also physically distancing. A monogamous partner, a partner who is also, again, physically distancing. There are some monogamous relationships where one partner may be physically distancing and the other is an essential worker, either a health care worker, works at a grocery store, places like that, places that are essential to our survival. And in these situations where one partner is physically distancing and another, some suggestions came where maybe introducing a barrier like a dental dam or plastic wrap for kissing and rimming and things like that. And then also mitigating harm by making sure that the partner who does go outside of the home leaves his dirty or their dirty clothes in a designated area and showers and puts on sanitized clothes when they come into the home. The other next safest person outside of yourself and a person that you're in a monogamous relationship with who you're socially physically distancing with is someone else who may live in your place with you. I'm going to let you to let you to use your imagination around that. But if you can verify that this person is physically distancing, and you live together, and the interest is there, hey, do what they're doing through that window. Okay, so how to safely date someone outside of your home? Virtual dates, and I know this may sound a little odd because we're so used to doing everything in person, but this is a novel virus, which is new for us all, and these are some new suggestions. Virtual dates. Some museums, like the MoMA, the Museum of Modern Art, have virtual art tours, guided tours that you could do with a person. You can engage if you want a little bit more sexy time. You can engage in phone sex, but not just your regular vanilla phone sex, but allowing yourself to imagine and go there with your partner. Of course, video sex is a way to see your partner and engage. I've heard of people engaging over FaceTime, even Facebook, or other apps like that. Understanding that while it does limit your risk for catching or contracting COVID, there is still risk in sharing videos over the web. And then there's apps that allow for you to feel like you're there with your partner. Certain apps that sync up to vibrators and other sex toys, so that one partner can control the motion and the feeling of the moment. And it feels like we're actually in this thing together. And if because a lot of people that I've spoken to, especially that work in Atlanta, have expressed, look, I'm with that calculated risk. Understand that having outside of sex out with somebody outside of your house who you cannot verify is physically distancing is a risk, and it goes in the face of the concept of physically distancing, right? While COVID is not a sexually transmitted disease, it's still, putting us in close contact with other people is risky, and it does put us in contact with respiratory droplets, oftentimes fecal matter, and other things like that during anal play. But because we're going to do it, our recommendation is that you take every precaution. Many of these next suggestions come from a healthline.com article where physicians actually provided solutions for people who wanted to have sex in real life. So, assure that your partner isn't exhibiting any any symptoms of COVID, but also understanding that your partner could be asymptomatic or pre-symptomatic. Take your due diligence to make sure that we're disinfecting not only ourselves when we before and after sex, but we're disinfecting spaces, understanding that COVID can exist on certain spaces for an extended period of time. So changing the sheets, and if you're having someone over your place, making sure that you're going to someone else's place, making sure that the space, the area of play has been properly sanitized. Limit droplets by maybe wearing masks. I've heard actually someone shared to me that they're having masks, using masks during sex now to avoid coming in contact with respiratory droplets. Sexual positions that put the mouth away from the body, so positions like doggy style or reverse cowboy or cowgirl. And if you're a person like me who likes to gaze at your partner, you want to feel that connection, maybe utilizing a mirror to look in the eyes of your partner. Understanding that transmission involves feces and respiratory droplets, limiting things like or avoiding things like kissing and rimming are important during this time. And of course, be sure that you are both practicing good hand health as well as having sex. I'm sorry, not as well as having sex before and after, but washing before and after you have sex. And most importantly, in this time, let's commit ourselves to being trauma informed for ourselves, to ourselves, good to ourselves, as well as the people in our networks and community. Understanding that this is a very new time for us, and understanding the role that loneliness plays and goes and makes in our decision making. It's odd to be in the house for months at a time without somebody else to touch you. Understanding that we are human beings, we need touch, we want touch. Validate and honor the physical and emotional struggles that are presented right now. Inquire about tools that they utilize that we utilize during the hardest times of the HIV and AIDS movement. Understanding and then learning from some of the mistakes that we made as well. Honor the role that our resiliency and strength plays in the struggle so far. And ask about safer ways to maybe, get off and remain COVID free. And then offer step-by-step tools and useful resources to those friends who may have, their interpretation of physical distancing has put them in some type of risk. And if they're exhibiting illness or anything like that, show compassion when connecting them with the appropriate medical resources. All right, additional concerns for people living with HIV. This is coming from the Department of Health and Human Services. If you're a person who is living with advanced stage HIV or HIV that is less or is more poorly managed, making sure that we're taking all of the precautions at this time to protect ourselves. Our regimens, as Dr. Chan said earlier in the presentation, our regimens should not be changed during this time to include Kaletra. Consider the risk versus benefit of going into and having live appointments, as some of our and a lot of our providers actually have gone to telemedicine options. And for people who have been sustained virally suppressed or, and are doing well, maybe considering, with your doctor, maybe postponing the next lab or in-office doctor visit. Again, additional guidance is that we maintain at least 30 days of supplies of our antiretroviral medications on hand, and if at all possible, contacting your medical provider or your insurance provider and seeing if we can go to a 90-day prescription during this time. Talk to the pharmacists and the healthcare providers about that 90 days. I was able to do it for myself as well as some of my friends. If your regimen is you're planned for a switch, you're going from one drug to the other right now, make sure that you're monitoring this closely with your medical providers to make sure that everything goes without a hitch. And again, additional cautions for people who are living with advanced stage HIV or poorly managed HIV, so that we're just making sure that we remain safe. Again, here's me putting on my mama hat. This is Mama Larry coming out. Make sure that we're making lists. I can't say this enough. It's important that we have current lists of our medications, as well as our emergency contacts, as well as our care providers and their numbers and things like that, so that not only having it in your wallet, having it in your cell phone as well, just in case one of those things were missing when you were admitted or a loved one was admitted into the hospital, so that we can maintain those medications and those contacts. And for anyone who is hospitalized during this time, making sure that we continue our HIV medications. I can't tell you how often enough that has happened. It has even happened in my own family where people were admitted into the hospital and instantly they focused on what was emergent and took them off of their medications that they take for chronic ailments, including HIV. It is essential that we continue our medications and continue to remain virally suppressed or on that road while we're going through whatever hospitalizations that we're going through, especially if you're a person or your loved one is a person who takes the evoluzumab infusions every 2 weeks. It's important that these infusions are continued and that they are not interrupted for any reasons. Their patient support number is on the screen right now. So if you're a person or you know of a person who is taking these infusions, please ensure that they are continued if they're hospitalized. So there's my section. We're going to open it up for questions and answers. But again, I just want to remind you before we do that it is important, as Jim and both Dr. Jan and Jim have said, that it's important that we look after one another, that we hold each other up, and we love each other through this trying time. I thank you so much, and we open it up for questions now.
So there are a few questions in the Q&A box, and there are a number in the comment section. If you have any questions about anything that we've heard today, please, that you've heard thus far, please feel free to ask those questions now. We're going to ask that all presenters please show their face, and I'll ask the first question. First question is for Dr. Chan. A person is wondering, why are we pushing masks and not gloves when this is also a contact virus?
Oh, yeah, that's a great question. I saw that one come up in the chat box. So, here's the deal with gloves. Gloves require a tremendous amount of discipline. So let's say you're going to the grocery store, you're wearing your cloth mask, you're wearing, a pair of, let's say, nitrile or latex gloves. You have to avoid touching your face, and you have to keep in mind that, your hands are, even gloves or barehanded, you can, if you touch an infected surface and, touch your nose, touch your eye, that's obviously a potential infectious event. And so, I think the CDC is avoiding specific guidance around gloves because they feel like it gives people a false sense of security from that respect. Obviously, if you're from an infection control perspective, if I was going to see a patient who I knew had COVID, I'd be wearing a gown, I'd be wearing gloves, eyewear, N95. And then taking off the gloves has to be done in a very particular way, to avoid spraying the stuff that would be on the gloves. And then, of course, you want to sanitize your hands immediately after wearing. So I think, it's to your individual risk profile. I think if you're a high-risk person and you feel like you can be disciplined, using gloves appropriately and sanitizing immediately after you remove your gloves can certainly be another protective barrier. But I think they probably didn't issue wider guidance, for those reasons. Does that answer your question?
Thank you so much for that. Larry, how is COVID-19 affecting HIV care seeking, adherence to treatment, and accessibility of care? And accessibility of care is what I believe.
So naturally, again, this is a new situation. A lot of places that have never engaged telemedicine before are having to go to telemedicine formats. So that has presented a bit of lag. I have to shout out Atlanta though, because a lot of the ASOs and CBOs and private practices around the city have figured out how to do that continuity, making sure that people are able to get their appointments and things like that. I think that the biggest way that it's affected it as a patient, or just wearing my hat as a patient, is just the angst around it, the more emotional kind of like, okay, what's this mean as a person living with HIV? The angst, the fear. Some people have had their appointments canceled and things like that, or rescheduled, which can kind of be stressful. But I can't stress enough the importance of having adequate support and, being linked to agencies that are nimble and are working with you to make sure that your needs are met, even in the time of COVID, because we don't stop being people living with HIV because of latest pandemics. So that's what I've seen, but I've seen a lot of creativity and adjustments being made on the behalf of a lot of CBOs and ASOs, especially in Atlanta.
Thank you so much for that.
Thank you. Just 1 second, Damien. I just want to remind everybody to do the evaluation. I didn't put that part out there. So if you're having to check out, please do the evaluation and everything like that.
No problem. Thank you.
Okay.
Jim, any suggestions for how to address or deal with disconnection during this time?
Mm-hmm. Yeah, I guess that's really important. I think the first thing is kind of pay attention to sort of our own need and understand what the need is. My own experience, as I said, is what I found is that my sort of usual ways of connecting, shoot someone a quick text or do an email in the morning, hasn't been enough. And so what I found is I'm doing longer conversations on phone. I've also really needed to see faces. So I've done more Skype and FaceTime and Zoom, not just for webinars, but just to see my people. So I think that, I think to acknowledge the struggle, to acknowledge how hard it is to feel connected when we're physically isolating, and I just want to acknowledge the particular burden of people that live alone. That people that live alone who are physical distancing, it's a really hard road. So sort of being gentle with yourself. I did some things about self-talk, just reminding yourself this is temporary, this is not the way we're going to live forever, and then really being active in terms of figuring out what the need is, reaching out, using media, but also maybe sharing at a deeper level than you normally do over a phone call. I really want to know about people's inner life. I want people to hear about my inner life, which I could do over drinks or food in a real setting. That doesn't come through in a text. So ask yourself, what do I need? Who are my people? What's the medium to try to get connection?
Also to that point, I think that is important that and not just with our clients and members and things like that, that it's important that we're reaching out to people. I think that Jim said it on the last training, that we're reaching out to people that we've not reached out to before, that we're going through and letting people know, I'm here for you. I love you. Remember that time we went to that cool movie and we thought of that guy or something like that? Just making sure that people are still able to connect in these times.
Beautiful.
Thank you so much for that, Larry. Larry, I wanted to follow up on the question that you answered a little bit earlier. Talk about what's going on in the Atlanta area, but are there any suggestions for people that live in rural areas? Because I think oftentimes we look at Atlanta or metropolitan areas, oftentimes those rural areas are kind of left out. So can you speak to some maybe groups or things that people can do to kind of seek those resources in areas that are not as populated?
Yes. Well, not to shamelessly plug the Thrive SS that's on my shirt right now, but we at Thrive, we can connect you to almost support anywhere you are. Finding people that are, if there aren't support networks and groups available in your area, definitely reaching out to us. We can link you to national support and things like that. But then also endeavor, similar to what Jim was just saying, creating that support, understanding that support is just, two or more people that are holding each other up, so maybe engaging people that who are also living in your area, who might be living with HIV or dealing with anything, or dealing with this physical distancing and keeping each other up and together. But again, tapping into the support networks. If you're a person living with HIV and you're living in a rural place right now, you are not alone. You are not the only person living with HIV in that space, and you're not the only person living with HIV who is going through this COVID situation right now. We're just here. We're here waiting to support you. So look out for support. If your doctors or your care providers are not on the telemedicine platform, maybe engaging them to see if what can be done to get provide those services for you as well. But definitely making sure that repeat the organization. The organization was Thrive SS. Thrive SS Incorporated is the organization that myself, Daniel Driffin, and Dwayne Bridges founded for people living with HIV, and we're great at providing support for people. Either we have the largest network of people living, Black men living with HIV in the country, and a network of women living with HIV in Atlanta. But we're connected to national networks. So wherever you are, and especially if you're somewhere where you feel like you're the only one, definitely tap into us at thrivess.org, and we will link you to support and family.
Thank you so much for that. We had a follow-up question along those same lines, Larry. Are there any online support options for folks with HIV, specific to COVID or not?
Online support options for people specific to COVID.
Mhm.
Support like
Support
support,
groups.
social support. Now, I haven't seen any social support groups for people living with HIV and COVID, but understand that most people living with HIV right now are having a COVID experience, either the angst, the energy, they know somebody. So connecting with people living with HIV networks is a great place to start. And at Thrive SS, we have a concept. Sometimes you have to be the person who makes the innovation. You have to be the person that takes the charge. So if there aren't any, I invite you to start something. We'll support you every step of the way.
Thank you so much.
Yeah.
Dr. Chan, can you discuss the latest information being circulated that warmer weather may bring some relief? If that were the case, why do Floridians contract the virus at the rate currently occurring?
Sorry, I was muted there. Yeah, that's a really interesting question. So, traditionally, what we say is that colder weather is drier, and drier cold weather leads to damaged, nasal mucosa, oral mucosa, and so viruses can penetrate, and people are, generally it's easier to get sick. So that's typically the thought process behind flu season. So then, there's this whole question of, well, initially, since it was March and the country was still kind of cold, there was this whole thought like, well, if we go into the summer months, will rates of coronavirus go down? I think what we've seen is that has not been the case. Certainly in Georgia, it's pretty warm here. Certainly we have some days in the 60s, 70s. And of course, Florida has a pretty significant outbreak as well. And so what I would say is that we can't count on that to bail us out. The flip side is, will things get worse potentially in the winter when things get cold again? There are some, virology experts who say, yes, this is way out of my wheelhouse. But so far, the preliminary answer is that we should be worried about that. And so the short answer is, don't count on warm weather to bail us out. Things could get worse in the winter, potentially.
Thank you so much. Dr. Chan, another question for you. If patients follow all precautions such as masks, gloves, washing their hands, etc., and there are no COVID-19 family members in their home, what are the chances of getting COVID-19?
I would say, if it's nice if you have like a group of people that you are quarantined with, and you can that they're following their quarantine precautions very strictly. I mean, I would say that you can resume normal activities around them. That being said, if you have someone who was diagnosed and then is coming back, I would really try to isolate that person as much as possible for the requisite 14 days. They should be wearing the mask, and anyone interacting with them should try to take as much precautions as financially and feasibly possible given our limited resources.
Hello?
Okay, sorry about the feedback. Dr. Chen, are you back?
Yeah, I'm back. But short answer is if you guys are all strictly quarantining with a nuclear group, then I would assume that it's okay to just interact with them normally. But again, I think you just have to know what the other people in your group are doing.
Thank you. If someone has been tested and was negative and later gets symptoms, should they get tested again? Is there any difference between the nasal versus the saliva test?
Oh yeah, this is a great question. A couple different points there. So if you're tested negative and then later on you have an exposure and you have symptoms, call the hotline again, get tested again, no question at all. I think so. There's a lot of different tests out there. The standard, I just should have gotten into this more, but there's the nasopharyngeal swab. It's pretty uncomfortable. They stick the tube, the swab in your nose, pretty deep in there. That's the PCR test. That one's pretty good, pretty widely available. There's another test that potentially is saliva, also can be blood. That's called the serology test. It's an antibody one. There's a lot of different ones on the market, but they haven't all been validated. And the FDA has been a little bit too lax, in my opinion, about approving these. So again, the PCR is the go-to. We're still working on the serology stuff. That is a very rapidly evolving area. I wouldn't necessarily trust the serology 100% unless this was recommended by a specific doctor or you got it as like part of a healthcare system.
Thank you so much. Is there any advices to all the panel? What is your advice for a person who is currently out of care, living with HIV, and now have fears around COVID-19?
I can start that. Find somewhere where you can get, confidential, compassionate, relinkage to care, and support. Understanding that, as it was purported in this presentation, that people with better managed HIV probably tend to do better with this COVID situation. But just trying to get linked back to care regardless of this COVID situation because it's the best thing to do for yourself. And in addition to getting linked to care, make sure that you're getting linked to a community of people who can host you up and build you up as a person living with HIV.
Anyone else? Okay, next question. Are there any best practices for telemedicine or telehealth care during this time? And just before anyone takes a stab at that, we will be doing a telemedicine webinar in a couple of weeks, maybe a week or two, and we'll be going over best practices of telecare. And we kind of term telecare because we're looking at the medical dimensions of health, the psycho dimensions of health, as well as the social needs as well. So we'll be looking at all dimensions of health, and we'll be providing a webinar on best practices, as well as giving people a forum to ask questions around telemedicine or what we consider telecare. But any best practices or any advice for people who are utilizing telecare or about to utilize telecare to kind of ease their fears around participating?
This is Jim. I'll start with a resource. I don't have the ability, or I'm not very savvy to go back and forth to Google this, but SAMHSA produces a series of guidance documents. The federal government funding agency for substance abuse mental health treatment. SAMHSA does a set of guidance called TRIPS, Treatment Improvement Protocol Series, TIPS. We'll get it in the chat box, or somebody will find it. But there's a tips specific to technology-assisted care, like just how to do technology. It's a whole range of sort of what are the legal things and the clinical things. And so that resource is public domain. If you Google SAMHSA tips, I'll try to find the number in just a minute, but a SAMHSA tip on technology-assisted care is an excellent resource about the nuts and bolts, again, how to get informed consent, how to do things clinically, and that resource is a public domain document that would be a great starting point.
Thank you. Anyone from the community side, as a consumer or person living with HIV, any advice to them on utilizing telecare during this COVID time if you've never done it before? Larry, Jim, anybody?
Oh, I'm sorry, I was talking and I was on mute. Yes, well, the people that in our network, one brother specifically, who is doing telemedicine right now, he initially was kind of like worried because, like, he's been living with HIV for almost a decade at this time, and he's never done telemedicine. And his comment was, he feels like we should have been doing this. Like, this is what we should have been doing, understanding that, in his words, he says, all I feel like is, the doctor just sits and looks at me as he tells me my labs, and they did it over the phone. And he was just like, this is so, convenient and cool that, like, even after COVID, he wants to do telemedicine. So.
Dr. Chan, is there any limitations to telehealth care as it relates to treating or managing a person living with HIV?
No, I think there's, very few limitations. A lot of my experience with telehealth is mostly like with our rural clinics, like we have some satellite clinics, so I'll do like some Hep C care for those folks. Essentially in the immediate term, like if you can get labs done remotely and anything else, at the core part of it, we really just need to be, doing STI screening appropriately, checking viral loads, making sure people are on meds and not having any toxicity. So if we can get through that, that can definitely be achieved through, telemedicine means, try to limit in-person visits. So, I would definitely be an advocate of expanding that as much as possible. I think there are some things that, simply can't be, shipped out, anal pap smears, obviously vaccination. But if we can get labs remotely, as much as we can do and with limiting human interaction, I think is probably the way to go.
Thank you for this. To the panel, what are your thoughts on using UV lights to disinfect during the time of COVID?
That's a joke, right? So this is Larry. I just feel like that sounds like maybe something that like maybe a kid came up with to treat COVID. I don't know, Dr. Chan. Is there any science behind that?
I think if you have COVID, like living on a surface that has direct exposure to UV light, certainly UV light is denaturing, and we definitely had some studies at Duke where we would make fun of this all the time, but they had this like UV robot that would like disinfect rooms. But as far as people, I don't have any scientific, knowledge or evidence to say that would be effective.
Thank you. We have a couple of people asked this question, and one peer advocate that wants to know about suggestions on getting things that they need to their clients. So after the telehealth visit, how do you get the people what they need when they need it?
Can I start? I think it's really important that people be willing to act as advocates in the world that we're practicing in today. And so whereas normally everybody was open and doing business as usual, I think there's a role to really challenge people to make sure they're doing what they deliver. I mean, I think for most people who receive Ryan White dollars, they understand the strong push from HRSA to continue services as before. It might be helpful as a navigator to use your network to remind people that their federal funder expects them to continue to be providing services in a way that, I mean, you don't have to pick a fight, but I think to really step up in a way that's safe. I mean, I think that's the challenge. It depends on the service, but to say, our consumers are needing something, you are funded to do that thing. Again, it's different if there's not that carrot of federal dollars, but I think most agencies get some Ryan White money. If you're taking Ryan White money, it's an expectation of your funder that you continue to do the best you can and then problem solve and be creative. If those services don't exist, to challenge the existing Meals on Wheels program to deliver to people you care about. the existing housing system to help your people who need housing. Again, where there just are limited resources, can you reach out and ask people to expand their scope to the consumers that you work with?
Yeah. To that point, Jim, that's a great answer. I went to school in the AU Center here in Atlanta, Morehouse College, and Clark's logo motto is "Find a way or make one." I find that very salient in this time. You know, we've had to send food bags to members in Uber. Just take this to a member and put it on their steps. Coming up with like a buddy system or systems to get stuff to people who are, may have transportation insecurity and things like that. I think this is because this is such a novel virus and such a novel time for us. We're having to, in the moment solution, come up with things that work for our clients and ourselves in this moment. So maybe working with your clients to see like what's the best way to get this information to you? What best works for you, and tailoring it to their need.
Thank you so much for that. Very good ideas. We do have another question about telehealth care. And like I said, we will have a webinar that covers this, but this is a very good question. Any ideas on which apps we can use to maintain HIPAA compliance and client confidentiality as it relates to getting documents signed and returned to us? I've heard that Google Docs has a forms collection thing, and it is HIPAA compliant, but all clients, like someone said, do not have smartphones. So determining the best way to get information back, a lot of Ryan White agencies, ADAP agencies, and some clinics are waiving like recertification documents, things like that. But yes, utilizing mail services is one of the ways, but there are a lot of different things that are being done to kind of like waive that whole receiving of documents back. But anybody else have any apps or anything to e-faxing? You can take a picture and send it in. I know that's works well as well.
Yeah, I was going where Bené's going, that in the age we're living with the distance, with the unusual circumstance, obviously for consents to care, those kinds of things, to take the verbal consent and sign on their behalf and sort of document that you got that verbally. I mean, I think, it's your lawyers would be thrilled about it, but if you explain in the time of social distancing with COVID, in order to get this person linked to services, enrolled in care, we took a verbal response to get them their medicine, get them an appointment, get them access to services. I think I'd be very surprised if anybody's going to litigate, even though, obviously requirement is a physical signature for a lot of the bureaucratic work that we do. I doubt that anybody's going to come back and face legal sanction as a result of that. I'd be surprised.
Thank you so much for that. Hold on.
I saw a question about reinfection.
Yes.
Did we do that?
I'm going back up to Dr. Chan. Do you want to speak on reinfection? So if a person has already been tested positive for COVID-19, what is the likelihood or probability of them being reinfected with COVID? Do they build some sort of immunity?
Yeah, that's definitely one of the $1 million questions. So I'll start by saying what we do know about other viruses. So with the flu, you certainly can get immunity to a specific strain of flu. The problem is as it goes around the world, it kind of mutates and changes its, pathogenic main pieces, the neuraminidase and the hemagglutinin. And so, you can get partial immunity to flu, but it mutates so rapidly, it reinfects people. Obviously, we have a flu season every year. With coronaviruses, there are probably like 5 or 6 circulating coronaviruses that cause the common cold and other things like that. Generally, the consensus is that you can get immunity to these individual ones. I certainly, when my kid went to daycare, I was sick like every day. And then now, I never get sick at all. But the problem is this is a novel virus, and, we just don't know. If you base it off of other coronaviruses, then sure, we should definitely be able to develop immunity. We should be able to develop neutralizing antibody. But I've seen some news reports, certainly, that people have been reinfected. You know, South Korea is one particular place. I haven't seen any specific, you know, case reports or, you know, publications in scientific journals about that, but that is definitely the primary concern, you know, because if that's the case, you know, then we're in a lot of trouble. But hopefully, you know, we'll be able to develop an effective vaccine. You know, hopefully, we'll get some meds that work. So I'm trying to stay as hopeful as positive, or as hopeful as possible.
Thank you so much for this. We have a participant that lives in Florida who lives in warmer weather, and swimming pool season is now approaching. They're wondering, will chlorine break down the virus in pools? I mean, will chlorine from pools break down the virus enough to kill the virus?
That is an interesting question. I think the problem is, you know, if you're going to a public pool, you know, people are presumably exerting themselves, and so, you know, I would just not go to a public pool. I think that would ultimately be a high risk spreading situation. If I don't know specifically if chlorine kills the virus. I mean, I would certainly presume so. You know, most of the data was about ethyl alcohol, and then I think one of the ammonium salts, quaternary ammonium salt concentration. That's where like all the sterilization data has focused. I mean, what I would say is I would not consider swimming in the pool to be protective, because if you surface and, you know, someone who has COVID breathes on you, you know, it's not like that air has enough of a chlorine concentration to neutralize the virus. So unfortunately, public pools would probably be considered, I would still consider them high risk.
Thank you so much. There have been articles in the Washington Post and New York Times showing false negative results for the test is up to 25%. How can we have faith in the new test to look for antibodies?
Oh, yeah, you guys are running the gamut here. So the serology, I mean, honestly, we could spend a longer discussion talking about the serology testing. I think the short answer is, you know, there's a lot of unconfirmed, you know, non-FDA approved serology tests out there. Currently, the FDA guidance is that if you have a serology test, then the FDA is kind of like, you know, prematurely approving it, or like proactively approving it, and then you can submit the data retroactively for continuing approval. And the concern is that there's a false negative rate, but also that there's a lot of cross-reactivity with other coronaviruses. So there may be a common cold virus that you show up antibody positive, you were exposed to that, not necessarily COVID-19, and then, you know, you have cross-reactivity, so it shows that you were infected with COVID. So I think there's a lot of problems with the existing serology tests. I would really have to dig more into the ones that, you know, are most strongly recommended or most highly recommended. But there's a lot of different ones that are circulating that are not, you know, as reputable, I would say.
Thank you for that. One of the participants was on a call, and they said the last COVID case mutated 26 times within a year. Do you know what factors cause these mutations, and is it like the mutations found in HIV?
I would say that they're a little bit different. So we do expect, you know, these kinds of viruses to mutate pretty rapidly, and this may just be one or two small, you know, point mutations, meaning like one single nucleotide base. With respect to HIV, you know, HIV, when it acquires specific mutations in the face of drug pressure, you know, you can get resistance to those meds. That's obviously the big concern with HIV mutation. There are lots of different HIV mutations that don't necessarily affect meds and are kind of insignificant. So with COVID-19, you know, there are probably some mutations that affect how deadly the virus is. There are probably some mutations that, you know, affect, you know, how it infects certain people or how it behaves. We're still learning a lot more about that, and we're learning more about all the different subtypes of the virus. But this classification and, you know, discussion is all occurring in real time. So something to definitely follow closely.
Is there any advice you guys can give to a person living with HIV, just in general, as it relates to living through HIV as a long-term survivor, as well as this new COVID environment?
Yes, definitely. With amongst our Silver Lining Project group, we hear that a lot about the re-traumatization that is happening. People remembering their last epidemic, and talking it out, finding some emotional support. It may not be a friend for this situation. It might be a therapist. Therapist offices have gone to telemedicine as well, and there's usually some type of emotional wellness support for people living with HIV. Don't beat yourself up. Again, understand that this is normal. Um, there was an amazing resource that was shared with us prepping for this presentation about the mental and emotional health side effects of going through a pandemic. That is a very helpful resource. It's helpful to know that you're not alone and that this isn't weird. You're not weird for feeling like that, but definitely seeking some type of emotional and mental health support.
For this. Yeah, I know we're past time. It is now 2:35. If any of you guys have to drop off the call, please feel free to. However, we do have a few questions in the queue. Please remember to evaluate this session. Please be on the lookout for. Please remember to also complete the survey if you are a service provider or know of any agencies in your area that are providing services currently. Please feel free to fill out that survey. Evan has put the links to both in the chat box and in the Q&A box. He'll drop them in that box again momentarily. But if you guys can't stay on the call, please feel free to. And we'll stay on the call to answer questions as long as possible. We do ask that each of you stay on the lookout for our series of webinars. We have a few more that are coming down the pipeline, and we'll be covering some very specific topics such as long-term survivors and the re-traumatization of living with HIV, as well as telecare. And we'll also be covering some things on race and a few other things that you guys have brought up. Okay, we have a few comments from some people that I thought would be good to offer into the space. We have one person said they've been living with HIV, and their doctor at Kaiser has been doing telehealth appointments for at least a year and a half, and one of their appointments are on video, so they appreciate the whole video. Raleigh Johnson said something that was very, very powerful. She finds it helpful to think collectively as a trans person. She comes from a long line of survivors and thrivers, those in the LGBT community and people living with HIV as well. She has faced and surmounted loads of challenges. This isn't the first and won't be the last, but we can weather this together while remaining at least 6 feet apart. So that was a very beautiful quote, and I thought it was great to bring that into here. Jim, could you elaborate a little bit more on that extra stage of grief that was mentioned in your presentation? Or to speak to grief?
Yeah. I'm not sure the question, Damon. The thing I mentioned in my presentation.
About grief. They want to know a little bit more about grief. Speak to grief.
Okay, yeah. I think what's important is that grief is a normal human reaction to any loss or anticipated loss. And so you start kind of from a frame of this is normal. It's a normal emotional state. I go back to something Larry said that seemed really important, to ask ourselves how people cope through hard times, and again, ultimately, talk, support, self-care really seem to be the themes. If you look at who survives trauma, who copes with grief, connection, I guess what we haven't talked about is purpose in life, a sense of spiritual connected. I don't think anybody here would say there's one path to spiritual connection, but those factors all seem to be important ways that people who experience emotional distressing circumstance, people who survive stigma and trauma, seem to resolve without lasting impact because of those things.
Thank you so much. With states opening up sooner or later, will STD and HIV testing be overlooked by those looking into re-engaging into behaviors they engaged in prior to COVID? So the question is, will STD and HIV services be overlooked by those looking to re-engage into behaviors they engaged in before COVID-19?
I'm going to take a start. I think there is a human tendency when you've been told to abstain from cookies, let's use cookies as an example, that once the door is open and nobody's looking, Austin, you know exactly where I'm going. You can't think of nothing but cookies. And you go out to the bakery and you load up on cookies. My hunch is some of us going to burst open the door when they say for real, this thing is over. And if there's something you've been missing, going to go ahead and do that. I think for those in the prevention business, for those who care about people, just to say we expect once the door is open and it's safe to do it, other than reverse cowboy and on Pornhub. Once you can take that ski mask off, Larry, some people going to be going for it. And so just to normalize that, and to say, but we value you, we care about you, and please, as you burst open the door and get back to your life, to not lose sight of, I think the message is, my God, you've survived this, you've survived COVID. Please don't go out and get no HIV or hepatitis or other sexually transmitted infections that are out there.
Yeah, like I agree. I definitely agree. Definitely start by honoring the fact that we're all experiencing this and that. Like a lot of people, it's a long time to go without sex, and maybe as professionals, we can utilize that understanding as a way to make sure that people know that they can that it is recommended that they get tested for all STDs as well as HIV, and that we're in our excitement about being able to engage again with cookies, that we're making sure that we're mindful and taking all of the precautions to keep ourselves safe. But I am a proponent of supporting people in sex and pleasure, because regardless of what you're living with and regardless of what is going on, we all deserve to experience pleasure.
I guess one last thing, I want to say, local health departments that are many of them just doing exceptional work. And so when we talk about HIV testing, this question seems to be about, will people forget to be tested? But what I'm clear about is most county health departments are really, really under a resource burden, are really strapped. And so, and they'll be mopping up COVID. So the question, will it be overlooked? I think even after some of us come out and say, I'm going back to the cookie store, the health departments are on COVID till the last case is done. Contact tracing, testing, clinical care, and so managing that burden of keeping people COVID-free, responding to COVID. I guess I'm thinking especially about partner services. Those contact tracers that usually knocking on your door telling you got gonorrhea are primarily focused on knocking on somebody's door, telling they've been potentially exposed to COVID. So the public health resources are stressed, and I look for that to be continued all summer at least, and then as Dr. Chan said, probably into third, fourth quarter once we see a resurgence, if that happens.
Thank you guys so much for that. We know some of you have other priorities. I know Dr. Chan may have to run back to clinic. So what we'll do, guys, is we'll go ahead and we'll wrap up. If you guys have any more questions, feel free to email them, and please feel free to email them. We have a ton of webinars coming. We'll also be doing a webinar on preparing the HIV workforce as well as consumers on life after COVID-19. So we'll be talking about HIV and STI testing and a number of things like that. But I know a lot of you guys have asked questions about race and about masks and race and things like that. We have a very specific conversation and live community forum on Monday from 1 p.m. to 3 p.m. We'll be sending that out as well. That's going to talk about race, the dimensions of race, religion, and poverty as it relates to COVID-19 or living through a pandemic. So feel free to reach out to us. We also have a self-care tips to manage difficult times that's coming on May 7th. So please feel free to reach out to us or register for any of these trainings. I saw Sheila said that DPH is offering condoms by mail. So there are a lot of innovative strategies that are being done, and we'll cover some of those things in our upcoming webinar series. I see that a lot of you are still on the call, and we really appreciate it. But what we'll do is we'll definitely continue these conversations, and we'll go deeper into these conversations in more, I guess I would say, specialized topics, so that they're not just these broad topics. We'll really dive into them a little bit more heavily. And we thank you all for your participation. Please remember to evaluate us. Please remember to complete the survey, and it's open to all states, so that we can combine that list of resources and send them out. A special thanks to all of our presenters, our moderator, and to you all. And we ask that each of you all stay healthy and stay well during these unfamiliar times. And we look forward to next time. Thank you all.